Hello and welcome to another week of core balance coaching. And this week's topic is spinal fusion. We're going to talk about what I would do if I had to get a spinal fusion surgery. It's a surgery that no one wants to get, but sometimes it's necessary. And before we get started, I do want to say that I'm not a surgeon. This is not my expertise. I've never had a spinal fusion. And this is not medical advice. I am just sharing with you what I would do. And so, just to get that out of the way, a little bit of a disclaimer: this is what I would do, and I'm gonna also talk about best practices in general. We're not going to be going over really like the details of what a spinal fusion is. That's going to be assumed that you're coming into this already knowing that. And we're not going to be demonstrating exercises today. I'm going to recommend rehab goals. I'm going to make best practices recommendations for strategy, what to focus on, mindset, the types of exercises to focus on. But I'm not going to be demonstrating. And so this is more of an education type video. And also it's going to be strategy based on, we're going to split it up into before the surgery and then 5 days after the surgery and that period, that inflammation period, and then the first 3 months, and then finally the 3 to 6 month period and beyond. So hopefully everything's working all right. My audio, welcome to the people that are here live. And if at any point you enjoy the content or feel that it's valuable, feel free to support the stream by hitting that like button and subscribe if you want to. We do this every week. So if you want to hear more stuff like this, so let's go into the topic. We're going to go to an image here. And this is just a picture of two different types of spinal fusion. Like I said, I'm not going to go into the details of what a fusion is, but basically what you're doing is you are fusing two levels or two vertebrae together. And so a two-level fusion would be fusing, in this example, L4 and L5, and also L5 and S1. So this entire segment of these three vertebrae would not move after the fusion takes place. A three-level fusion would look more like this. So 4 different vertebrae fused together. There would be no movement in these vertebrae. You are removing the mobility between these segments. And so they're all, any movement that would normally go into these segments would either go into the levels above or the levels below, which in this case would be the SI joint or the hip. And so this is part of the problem with with spinal fusion, is that it can create problems elsewhere in the spine because you are taking away what was once a very mobile segment and making it so that that mobility does not happen anymore. And if you're going to do a movement by like reaching for a cup, the movement's going to have to come from somewhere, and it's most likely going to come from the next level above. Okay, and so there is a disproportionate amount of movement that goes into this next level, and so the problem occurs when this starts to break down, or here this starts to break down, and then that's when they, years later after a spinal fusion surgery, we have a recurrence of symptoms. We have new problems that are forming in these adjacent joints, and you'll hear talk about adjacent levels of the spine are the things that will get more degenerated. And then there's a possibility to have a revision surgery or more levels fused. So then years later, if the problem persists, you might need to get now this level fused. And so actually I've heard it called chasing the instability. So You don't want to do that. This would be a main goal to avoid if you had to get a spinal fusion, is to avoid chasing the instability by having to later get this level fused and then later get this level fused. And that means more surgeries, more of the things that we don't want. And so I'm laying this out here right now to kind of set the stage as a goal, because this is avoidable. Actually, I believe that the outcome of a spinal fusion surgery is largely dependent on the rehab process and the way that we treat our bodies after the surgery. Probably more dependent on that than the actual surgery itself, assuming that you have a good surgeon. And that's a more of a the surgeons are highly skilled, and it's more of a predictable thing. So yeah, maybe the surgery is 50% of the outcome, but it's something that's in a professional's hands, and they can have control over it. And assuming they do a good surgery, which I believe they've gotten very good at, and most of them do, then the other 50% is in your control. And so we're going to talk about the strategies to avoid having to get a revision and to have a successful outcome with decreased pain and increased function, to be able to do the things that you enjoy doing in life. So I do have some slides prepared, so let's see if this works. So the very first thing is your mindset. It's a very important part of all of a back pain rehab process. And I do want to say that everything I'm saying today is actually relevant, highly relevant to anyone that has chronic lower back problems. All of this stuff, these kind of concepts do apply, especially to someone who is wanting to avoid getting a spinal fusion surgery. If you can avoid it, then that would be the best thing to do. And all of these strategies will apply to you, because we're trying to achieve the same thing, which is stability in your core, so that somebody doesn't have to come in and put in metal plates and screws to create that stability. But like I said, sometimes it's necessary, and so we'll talk about some reasons why it would be necessary. So here's the mindset. This fusion surgery is not the actual solution to the problem. It's a step towards the solution. And the solution is going to be that 50% of the rehab that you do. So say you have an instability in your spine. Maybe it's from a spondylolisthesis or degenerative disc disease or herniated disc. All of those things ultimately lead to decreased stability in the spine, because the tissues are compromised. And so the fusion will fix that damage. It will. But it will not solve the problem that led to that damage. So we need to go one step higher up in the chain. We need to go upstream of the damage itself that the fusion is fixing, and look at what caused that. And the surgery does nothing to address that root cause. So it's a step to allow you to do the exercises that you need to do to address that root cause. Okay, and we already talked about this. It's largely dependent on the post-op rehab. So we'll go to the next slide. So before the surgery, here's what I would recommend. You want to go into any surgery, knee surgery, whatever, shoulder surgery, as strong as possible. So you want to get your body strong. And I would be exercising as much as you can and working out as much as you can up until the day of the surgery, because you're not going to, especially with a spinal fusion, you're not going to be able to do that kind of stuff for a while. Okay, so also I recommend educating yourself as much as possible. Read articles, watch YouTube videos, learn as much as you can about the entire process. Personally, I would recommend learning some movements that they're going to teach you after the surgery, but it's a lot easier to learn these things before the surgery than after, because your body is going to be in inflammation, your neuromuscular system is going to be kind of just off, and so you'll be at a great advantage if you learn how to hinge at the hips, how to log roll, And I also recommend getting slip-on shoes so you don't have to bend down and tie your shoes, or even to put them on. You should have shoes that you can, or slippers that you can just get on without even bending down. And then I highly recommend a corset brace. So let's talk a little bit about why you need to learn these functional movements. So with a fusion, the one really important thing to know is that a spinal fusion, the actual fusion part of the surgery does not happen in the surgery. They are only setting you up for the fusion, which takes place over the next 6 months after the surgery. So you are not fused after the surgery. You just have metal plates and screws, and they are holding your bones together until they fuse. And that, depending on your age, can take 3 to 6 months or maybe even longer. And so this is a really important thing to know, because you're going to be given precautions that which mean things that you need to avoid, which is bending, lifting, and twisting. If you do repetitive or excessive bending of the spine, you're going to loosen the hardware. And that is inevitable. That will definitely happen if you overdo things, if you bend too much, too often, and ultimately screws will get loosened. And so same thing with twisting. So you have to learn how to move your body and do things in life without bending the spine for a while. And so that's why I highly recommend practicing and learning the hip hinge. This is something that a lot of people probably could learn, that hinging at the hips does not involve bending the spine. You can actually fully bend at your waist, and I'll demonstrate it right now. I can bend at my waist completely, and that is not bending my spine at all. There could be zero movement in my spine from that. And so to learn how to do that effectively is extremely valuable, and I recommend practicing it before the surgery a lot. Get used to it. Another thing is a log roll. You got to get out of bed sometimes. So this is the technique. I'm not going to teach it today, but I recommend learning and practicing the log roll before the surgery, so that it's a lot easier when the physical therapist comes into your hospital room and asks you to log roll. You got to get up to go to the bathroom. You already have some practice. And we talked about these too. So the one thing I want to say about corset brace is that different surgeons will prescribe different types of braces. And I've worked with a lot of spinal fusion patients over the years, probably over 100. And some surgeons prescribe a TLSO, or like a brace that has metal supports along the side, and it doesn't do anything to actually support the spine. All it does is prevent someone from breaking their precautions. So it kind of is like if you think about bowling, it's like the gutters, the guardrails for the gutters. It prevents the ball from going into the gutter, but it doesn't actually make you throw the ball better or guide the ball. You can still miss all the pins. So the corset brace actually squeezes your torso and supports the spine. And so I highly recommend getting a corset brace. You can even just go to CVS and get one and bring it to the surgery with you, just in case your surgeon happens to give you one of those TSLO or whatever braces that just have metal brackets. It's just not very effective for supporting the spine at all. So, you can't see my slide right now, so here we go. So, corset brace. Okay, I do highly recommend that for after the surgery. So bring one with you just in case your surgeon doesn't prescribe. Sorry, I'm throwing around my words today. It doesn't prescribe one for you. Okay, so we're going to talk about the first 5 days, and then we'll talk about 0 to 3 months and 3 to 6 months after this. So First 5 days after the surgery, this is kind of the inflammation period. Your body is going to be swollen. You're going to have, you're going to be taking a lot of painkillers, most likely, and you're going to be just wanting to rest a lot. And so that's what I would use this as. You're going to be getting a lot of mixed signals from your body and like inaccurate symptoms and signals. You might even get some nerve symptoms from the swelling, pressing on nerves. So I wouldn't rely heavily on how I feel during this period. I would actually just be patient and wait for this inflammation period to go down. Your rehab goal during this first 5 days, you might spend a couple of the days in the hospital, is to learn the precautions, no bending, lifting, twisting, and practice the functional movements, the hip hinge, the log roll, bed mobility, transfers. You'll learn all that stuff. I don't have to teach it to you now. That you'll have a physical therapist that comes into your room and teaches all that to you. The one thing you do have control over is your diet. I would be focused on an anti-inflammatory diet because there is so much inflammation. That's green food, green vegetables, vitamin C, fish oil, and then healthy proteins. If you can source them, if you can have somebody bring you good food into the hospital, I would be recommending. That's what I would do. I would have. If the hospital food wasn't high quality, I'd be getting high quality meat and high quality food that just can give my body the sustenance that it needs. For rest, I recommend, so this is another thing you have a lot of control over. You're going to be in a hospital bed. The hospital bed, you can put your feet up, you can put the head of the bed up, and I would recommend, because this period of the recovery is almost kind of like a reset. Like your body is going to go through trauma from the surgery, and so if you are sitting up in bed and kind of hunched forward and your feet are elevated, that you don't want to start off the reset of your body in that position. So I would recommend keeping the bed flat if you can, if it's comfortable, not elevating the legs, and having kind of a straight spine during that time. And if your hip flexors were tight before the surgery, maybe this reset can help them lengthen out because you have that metal support in your spine. And if you're just resting in a kind of a flat bed position, they can learn to rest in that lengthened position of the hip flexors. So, but not all the time. You don't need to be a mummy. So you can elevate the head of the bed, watch TV for a little bit. I just wouldn't spend all day like that, and I definitely wouldn't sleep like that. OB is out of bed, so I would be getting out of bed often with the corset brace, initially with the help of a physical therapist. Your mindset would be to think of this as an opportunity. This is a reset, and to have patience. You'll be getting acute physical therapy. You'll be working on bed mobility and transfers. So definitely take advantage of that and be using this stuff to get out of bed 10 times a day, at least. Exercises, there's a lot of discrepancy on the internet about exercises. So, I did some research before the stream, and I found surgeons who would say no exercise at all. Okay, I don't agree with that. What they don't want to happen at all is movement of the spine. They don't want the hardware to get loose, and that's the big fear of the surgeon. So I definitely recommend exercise to keep the muscles active, and so that would entail isometric exercise. So the spine doesn't move, but the muscles are engaging. And so if you were going to relate this to an exercise in the core balance training program, it would be the back anchor awareness exercise. And the breathing, I would be doing that in the first 5 days for sure, because it doesn't require movement of the spine. And so that would be what I would do, but I'm not prescribing this exercise to you. It does require body awareness to learn how to do this, to be able to do this without moving the spine and without, potentially compromising the hardware. And then definitely walking is going to be a huge part of recovery from day one. Although if you can walk from day one all the way through, so we'll talk more about walking in a little bit. So that is first 5 days, and we'll go through the next 2 slides, and then I'll answer any questions in the chat. So here is 0 to 3 months. So, after the first 5 days, you're going to have this period of time. So, like I said before, the fusion does not happen during the surgery. So, this is a critical period for the fusion to happen, for the bones to fuse together, and you really don't want that. That's the top priority. You don't want to loosen the hardware. You want this to be successful so that you don't have to go back in and get another surgery. So the rehab goal is to activate the muscles, because a lot of the times core muscles will shut down after trauma, especially the abdominal muscles tend to shut off. The glutes can shut off. And so you want to kind of activate these muscles just by contracting them and squeezing them. And another rehab goal is to maintain the strength that you built up before you got the surgery. Remember, we want to go in as strong as possible. So just try and not lose that, because if you do nothing for this period of time, you're going to be losing more strength than you can imagine. So I really don't subscribe to the idea that you should not do any physical therapy during this period. You can do strengthening exercises. You can keep your core muscles active without moving the spine, and that takes skill. It actually would be best if you practice this stuff before going into the surgery, so you know that you are able to keep your core stable. And so the core balance training is a good thing for that. I really think that most of the program is core stabilization, and so you could really do the program before the surgery and then be applying the things that you feel are that feel good for you, that you feel confident with, even in these first 0 to 3 months. Back, anchor, awareness especially. So not strength. We're not trying to build strength or flexibility or progress your fitness level during this period. And my recommendation for rest is to rest horizontal. This isn't really rest, but vertical. So laying down or standing up. So try not to be L-shaped. Try not to sit too much, because it does just kind of stress everything a little bit more. But let comfort and pain be your guide for that. So if everybody needs to sit. I'm sitting right now. So sit as much as your body tells you it's okay, but you start to feel pain, stand up or get horizontal. Those are preferable positions to be in. You want to gradually increase your out of bed time during this period to the point where at 3 months you're pretty much out of bed as much as you were before the surgery, or even more, right? So just a normal life by the end. So you're gradually increasing everything as you go. Your mindset is to prioritize your body and your health over trivial things. So we're faced with decisions we have to make every day in life. Should I do this? Do I have to do that? I have to get the mail. I have to do these things. I have to pay the bill. I have to do whatever. After I went for my walk, I'll do it after I, did the thing that I need to do for my back. After I eat this healthy meal, after whatever it is, it's a lower priority and the reason is because even if this thing that you have to do is important, it's trivial compared to having the full use of your body for the rest of your life. So it really is trivial. You might think it's important, but I would argue that anything is less important than health. So so that is just really important mindset to have when you're making decisions in your day. The next one is to listen to your body as a guide. That's a mindset that you live in, and it's not just like this. It's more like a constant dance that you are constantly listening and constantly making decisions on how much is too much, and how much you can tolerate, and your body letting you know that you did too much yesterday or a few hours ago. So reflecting on that and using that knowledge to guide your future decisions on how much you can do. And then just very slow, gradual progression of things. So we're not trying to accelerate or build or grow as a priority. It's just really, just the same thing as you gradually increase your out of bed time. When we're talking about exercises, you're gradually progressing these gentle movements. So in this second phase, we're adding gentle movement to isometric core engagement that we were doing in the first 5 days, the back anchor awareness. So what does that mean? There's exercises like the heel slides, fallouts, which is where the knee goes out to the side and you bring it back in. This is real slow, gentle movement. And the whole goal is to learn how to move your hips without moving your core. So you stay engaged in your abdominal core and you learn just gentle hip movements. So you can look those up on YouTube or ask your physical therapist. I would eventually, in these first 0 to 3 months, maybe the second half, like after the first 6 weeks, I would be doing, personally, I would be doing it earlier because I know how to do it without moving my spine, but low bridging, low bird dog, and low dead bug. So not to the maximum range of motion, just real gentle and light versions of those things. But personally, I would be introducing bridges probably, after those first 5 days. I would just real controlled, having my body awareness, knowing that I would feel it if my pelvis was tipping forward or tipping back too much. I would be doing bridges as soon as possible, just because the one thing I want to say about there will be people who say don't do exercise, but you have to get through life. You have to get out of bed. You have to get up. You have to go to the bathroom. You have to take a shower. You have to bend down and pick something up. This is not that different than exercise, right? It's functional movement. And so to say that you shouldn't do any exercise would be, to me, it would be also saying that you shouldn't get out of bed or you shouldn't move your body in a functional way. So the fact that you have to do these things, and if you don't, then you're going to turn into just a pile of putty. You'll melt into the bed, and I don't know how you're going to go to the bathroom, right? The fact that you have to do these things means that I would want to do them well. I would want to do them in a functional way with my core engaged. And so these exercises that we're doing are prioritizing. It's a training ground for how to do that. Core engagement, move leg. Core engagement, move arm. So I can move my arm or my leg, and none of the movement goes into my lumbar spine. And so that is primarily why I do recommend this kind of stuff at the bottom here. Okay, so a low bridge is a functional movement. If you need to scoot in bed, how do you scoot? Well, you use your legs, and that is a form of a bridge. And so, it's something that we all have to do. So why not practice doing it well? So that is recommendation for 0 to 3, and then let's go to 3 to 6. Gotta adjust that. So this period is I'm calling the continued healing and fusion period. So it's not done fusing yet, especially if you're older. Somebody that's younger will most likely be able to fuse by this time, but I would say most people that get a fusion are in the later years of life, and they may still be their bones still may be working on that fusing. It's hard to know. I'm not an expert in this field, but I still want to be a little bit cautious. So the rehab goal is low-level core stability and hip mobility. Bed rest is normalized by now. Your mindset is the same, really. Prioritize your health over all the trivial things. This is a critical period of healing. Home exercise program with physical therapy, walking. I didn't mention this before, but I would be walking at least 5 times a day in this period, 0 to 3. So I can't believe I didn't even mention it at all. But that would be my primary form of exercise in 0 to 3 months. And also 3 to 6 months, I would be walking at least 5 times a day. And I'm not talking about like walking to the kitchen. I'm talking about going outside if the weather's safe to go outside and going for an actual deliberate walk and coming home and saying, okay, that's walk number 1. I did it in the morning. Walk number 2 is in an hour or an hour and a half. And how far to walk? There's no limit. I really don't think there should be a limit. I think the guide of listening to your body should be your limit. So if your feet get tired or your core gets tired or it becomes unsafe or whatever, you should know how far you can walk just by gradually progressing each day from day 1. So you're in the hospital, you're going to walk down the hospital, the hallway with a physical therapist. You get back to your bed. Ooh, that was really tough. I'm tired. Or that was pretty easy. I think I can go a little farther next time. And so you're going to progress that way. And so ideally, if you can walk a mile 5 times a day, that'd be phenomenal. And it's not going to do any damage. And that would be my primary form of exercise, especially in this 0 to 3 months and continued into the 3 to 6 months. So, prioritize HEP and walking. So I need to go run this errand after I do my walk because that's more important, because the rest of my life, having my full functional body is more important than the errand is right now. So listen to your body, very slow, gradual progression. I would definitely recommend core balance training in this period. I can't recommend it earlier than this because it would be against precautions, and so you have to listen to the doctor. You have to listen to what your doctor tells you. You make that decision, but I cannot recommend anything to you. Personally, if it were me, I would be doing the things in core balance training that I know are okay to do earlier, but I cannot recommend that to you. So for those things would be, definitely bird dog or front anchors challenge, controlled bridge, and even a really minimal modified back anchor challenge or dead bugs. So, but for 3 to 6 months, I can recommend, unless your surgeon is very conservative and says nothing for 6 months, which I do disagree with. I can't recommend to those people. But for all others, I would say you could do core balance training. And then exercises would be continued focus on core stabilization, hip mobility, strength and flexibility in the hips, and thoracic spine mobility, which is basically what core balance training is. And I would also be taking advantage of physical therapy, going as much as possible, doing that simultaneously and having the hands-on treatment and the guidance that a physical therapist can offer in person. So that is everything. I can't believe I went like 35 minutes on that. A lot of information, I know, but I do have a bunch of questions to get to. So we'll take a look into the chat right now, and then we'll get to the questions. So Hello, everybody. Hello, Beth, Kevin, Sherry. You said you have had some doctors suggest the procedure. Uh, I have also had a spinal fusion suggested to me. So you could assume that to me does not mean I'm going to go get one. You have to make that be your decision based on the amount that you're able to enjoy life and the hope that you have that you can continue to get a little bit better each day based on everything you've been doing before. So let's see. Thank you, Marina, for letting me know my volume is good. Hello, Kara, El Poquito, Sue. Never have had issues specific to this, but I can see my neck needing lots of help in the future. A friend had neck vertebrae fused. Looked painful to me at the time. Neck fusion is a little bit different than this. It really limits you more than a lumbar fusion because we use our neck to look around so much. And so I would be giving a different presentation if it were about the neck. So, I can't get into that today, but thank you for sharing. Joni, I'm so dizzy getting desperate to do something. Would lower back and upper neck fusion help? We can talk about, I have a case example that we're going to get into next. So I'm going to get into scenarios where it would help. But in general, if you can avoid it and be able to do the things that you enjoy in life without that surgery, then that's what I would recommend. But there are cases where you need it, and we'll talk about that in a minute. Artho225, you're very welcome, and you've had a reduction in pain. That's great to hear, Rick. Kings Create, they had me walk in same day after surgery, L4-5 laminectomy, disectomy. Everything just held together with scar tissue and a prayer. So Kings Create, so that's not a fusion, right? You already know that. A laminectomy is just the removal of bone that was impinging. But so that'll be less invasive, but it's phenomenal that they had you walk in same day. And I hope you never stopped walking. Just keep walking, and that'll be a fantastic thing. Hello, Guillermo. Keck, I'm a couple weeks into your program, loving it. You're very welcome. I appreciate having you in the program. Keck Lynn. Kings Create. I was too young at 27 for fusion, so they did laminectomy. Okay. The same advice. Yes, same advice for sure. So you want to stabilize. Edwin, 2 disectomy, L4-5, sciatica due to a pinched nerve. The doctor meant to do a 2-level fusion, and I want to avoid that. Oh, he wanted to do a 2-level fusion. I can definitely see how you would want to avoid that. And I don't know if you're in the program, Edwin, but that would be something to consider that a lot of people have had success with the sciatica. And definitely a disectomy does absolutely nothing to stabilize the spine. So it just removes the part of the disc that may have been causing pain. And so you still have to do everything else to help stabilize the spine that you would normally do without that surgery. And Kathy, lumbar fusion is planned in a couple of months due to severe spinal stenosis and spondy. I'm in module 3, but having more and more electric shock pain and sciatica. So Kathy, it sounds like you have an instability that has already been diagnosed, and it's possible that the fusion would be the best thing for you, because if you don't have that structural stability, there's a point at which there's no ability for the muscles, the core muscles, to provide that. You need some level of structural stability, and that's kind of the conversation we're going to get to in a minute, is at what point do you need the fusion? And that's going to improve your life more than not getting the fusion. And so that's the point. And so if you're not able to do the exercises, I would recommend, Kathy, that you just stay in module 1 and maybe module 2. When you get really, really confident and a strong core engagement with those, then module 3 and module 4 you can start doing. And then, if you have a surgery scheduled, you want to get into that hip hinge module, which is module 5 as well. But that'd be later down the road after you have really gotten your core connection strong. I can see that I'm not catching up in the chat, so I'm gonna do. I'll draw the line here with Charles, who just posted, and then I'll go into my slides. So Edward Bove, I've had intense lower back pain, herniated L5, PT injection without success in the first week of the program, dull pain when I do breathing and bridges. Is that okay? Yeah, I've written a lot about that in the FAQs, Edward, so I would recommend checking those out. But for now, what I will say is dull pain is typically okay. There's different reasons, but you want to differentiate between whether it's bad pain or good pain. And sometimes dull pain is often good pain. And it's okay to play with that a little bit. You can get the benefit from the exercise, and the dull pain may not actually be a sign of damage. Of maybe it could just be stiffness in those joints. And so you got to really tune into your body and use your intuition to decide, is this my body telling me to stop, or is this some dull pain that I can kind of push through? But a lot of the time I would say it's okay. NPE, hello. Will there be naysayer segment today? No, there won't. Sorry, but we may put that in the future. I'm glad that you look forward to that. Kings Create, what are your thoughts on Jefferson Curls? You know, I don't think they're going to be the solution. And I think that more than anything, I think they just prove that flexion is not really that bad. But they're not the solution. Charles, hey, Dr. Ryan, sorry I joined late. You must have covered this. How much does a bilevel lumbar fusion limit mobility? I haven't answered that question directly. So I don't know, because I'm not an expert in fusion, but if we're talking bilevel, we're going to be looking at something like this. So 2-level. And so you're gonna get, normally we get, a little bit of mobility here, maybe a few degrees, and a little more mobility here, maybe a few degrees. So you're going to be missing maybe 10 degrees total. I don't know. There's probably research out about that. So you're going to want to have 10 degrees more mobility in your hips, because you don't want that 10 degrees mobility going into this level, because then this level is going to wear down, and then you're going to have to eventually get surgery on this level. So we want to increase the mobility in the hips, and that's why the rehab goal, especially at the 3 to 6 months, is core stability, but also hip mobility. So good question there. We're going to go into we have a case example. So this entire stream topic was because we have a student in the program who's in the coaching hub who has a surgery scheduled for June 26th, which is next week. And so, yeah, I wanted to do this. I thought it would be appropriate timing, and I figured it would help other people as well. So Kate has surgery scheduled, and this is a little bit about her history, and then we'll answer the questions that she had in the coaching hub. So she has a grade 2 double spondy, 4 breaks at L4, L5, affecting S1 with a spondy. This all happened because at 15 years old, she fell out of a tree 20 feet and landed in the sitting position. So that just caused the fractures. She's had back pain ever since, and has been progressing through the years. And as well, chronic Lyme disease is a comorbidity or another factor. So that is an example where, falling out of a tree, having a trauma, could be a reason where you need a fusion, and there's no real other way around it. And so you can get through. She got through a lot of life. She's 46 years old now, and she was 15 when it happened. But as you move through life, those compromised tissues can break down even more, and so it maybe has passed a threshold, and those tissues have gotten to the point where they're worn out enough that they need a little extra support. And so in this case, a fusion could be a very good thing. I believe it could improve Kate's life drastically to have this extra support from a plate that is put into the spine to support it. And, I said in the beginning that a fusion is not the solution, right? I said this is not the solution, it's a step. And so here we are with that. And so what I was saying about that is the fusion doesn't solve the original problem because something led to the instability. Well, in this case with Kate, she fell out of a tree, right? So, well, it is kind of the solution to the original problem because it wasn't a gradual progression of back pain from muscle imbalances. But the thing that really throws a curveball in this is when people have a traumatic injury to their back and the back pain, and it doesn't recover all the way, muscle imbalances start to form as a result of that. So most likely there are also muscle imbalances that are keeping the problem in existence. And so even in the case that the fusion is needed from a trauma, a physical trauma, like falling out of a tree, it's still not going to be the all-encompassing solution because there will be imbalances in the body that are resulting from the years after that trauma took place that prevented the body from healing completely. So there will be compensations. Certain muscles tighten up to try and create stability where there is an instability, like the hip flexors or osteophytes form, or all these things happen and the body is reacted. And so there is still another thing that needs to be addressed. And just re-emphasizing that the spinal fusion is not the solution and that there's more work that needs to be done. And I think that more work is largely going to influence the outcome of your surgery, is the work that you do after. So let's keep going with this case example here. And so she, 46 years old, very active landscaper farmer, tried for 8 years to avoid surgery with physical therapy, massage, core balance training, and reducing activity, but it's really starting to affect her life, livelihood, and personal life. So yeah, this is a scenario where the surgery can improve the life. And I wouldn't say to avoid spinal fusion for everyone. So I wanted to make that clear. And here are her questions. What should I do exactly after surgery for CBT Rehab? I find CBT much, much better and more affordable than physical therapy. So I mentioned earlier, and I'll just reiterate, I would be doing the back anchor progression, or sorry, not the progression, because that involves a little bending of the spine. So that's where you draw the line. The back anchor awareness and the breathing. So day 0 and day 1, immediately after surgery. So that, you can just activate those muscles without bending the spine. You can do those in the first 5 days, or you can wait those first 5 days. It's not going to make a huge difference in your large picture outcome if you just take it real easy in those first 5 days. Number 2, how to continue with CBT. Advice or insight of having back surgery and getting back to being my normal active self without having all the pain and fear. So this is kind of a big question, but I kind of went over it earlier that I would definitely be doing CBT after those first 3 months, the 12 weeks. And this second part of the question, without getting back to your normal active self without having the pain and the fear, is really, that's kind of there's no like one thing you can do. This is a constant struggle that we have to deal with on a daily basis of making decisions. And this is my best advice for this, is make the decision of, what am I going to do? What do I want to do right now? Okay, I want to go do this activity, and it might hurt my back. It might hurt my fusion. So make the decision before you do it. Am I going to do it, or am I not going to do it? And then once you commit to that decision, you do it with confidence. So if you decide, yes, I'm going to do it and I can do it safely, then do that thing with confidence. Because if you do it with fear, then it will have an effect on your body, your muscle engagement, the firing pattern in your body, and it can lead to unhealthy movement patterns while you do that activity, which is worse for your body. So if you choose to do it with confidence, and if you choose not to do it, then do that with confidence. Just be proud that you decided not to do it, and find something else to do that you can feel confident doing. So that's my best advice for the second part of your question, Kate. And then the third part is her main concern, knowing exactly what to do after the 6 weeks of recovery from surgery besides walking. The one thing I wanted to say about this is that I feel that some spinal fusion surgeons will almost kind of advertise that you can get back to your normal life after 6 weeks. And I don't know if I'm seeing it correctly, but I know from experience of working with hundreds of spinal fusion patients that after 6 weeks, you're not back to, there's still a lot of precautions. There's still a lot of things that you can't do. And so this 6 week mark is not really the turning point for me. I think it's more of the 12-week mark. And that's why I kind of split my timeline into more where are we here? I split it into 0 to 3 months, and then I split it into 3 to 6 months. So I think maybe that 6 week mark, there's no real change, and I would recommend following this timeline more so, because with being 46 years old, I don't think the bone will be fused by 6 weeks, and so you're still going to have to follow those precautions, no bending, lifting, twisting. You still want the top priority to be the bone fusing. That's more important than everything else. And so that's just my recommendation. And I did say that maybe after 6 weeks you can start introducing low-level movements with core stability, so isometric core engagement, but then adding in some hip movements like the bridge. So low-level bridge, low-level bird dog, low-level dying bug. So basically modules 1 through 4 of core balance training, but nothing to the maximum, nothing to end range of arm and leg movements. That would be pulling on the spine a little bit too much, and I would just save that for after the 3-month mark. And everything is gradual, so it's not like a light switch where you're like, oh, I got to 3 months, so I'm going to go here. No, you go 0, 1, 2, 3, 4, 5, 6, and so you got to look at it as there's no like day where you're free to just go crazy. The day before, 2 months and 29 days, you're doing something kind of similar to what you're going to be doing on 3 months. And so that's just the way I would look at that. And so that is everything. So we're going to kind of switch gears and go into the next portion of the stream, which is the student hub questions. I'm going to take a quick look into the chat and see if there's anything else. Just Ellen. Hello, Ellen. Good to see you, core member. Always happy to check in. I'm always happy to see you when I do. Here, Ellen, thanks for showing up. And let's get into the next portion of the stream. So we got Student Hub Student of the Week, Elizabeth Monticue. Congratulations, and thank you for your participation in the Student Hub. We want to recognize you for being intentional with your progress and listening to your body before moving forward. I can't say enough about how valuable that is, and I hope that inspires other students to do the same. So we're going to give you an extra month to your membership. You have to do nothing. We'll add it from the back end. So thank you again, and congratulations. So let's go to Student Hub question number 1 from Matthew Gerber. I received an MRI showing I have a mild L5-S1 disc bulge, which looks like it's seeping a bit into the nerve. Okay. Does the bulge always move in only one direction towards the sciatic nerve? How does one know whether extension or flexion exercises are therefore beneficial versus the other type, which would be harmful? That's a really good question, Matthew, and I think that is a question that I had, and I still have, back when I was, exploring the solution for my back pain. I remember asking a chiropractor, which one is bad for me, flexion or extension? And I remember his answer clearly. He said, I was hoping that you weren't going to ask me that. And so I think that's actually a pretty good answer, because the only way to know is by trying, and I wouldn't recommend trying it aggressively. I would recommend trying a little bit of extension through the cobra subtly, and then not doing anything else. Don't add more complications to this diagnostic exercise. So do a couple light cobras and then get up and go about your day and see if it changes anything. If you might experience an increase in pain, you might experience a decrease in pain, or you might experience no change. And so that's the only way to know. And it would be the same thing about flexion. So you would go about it the same way, and then you would learn about your body through that. And this is specific to a bulge, because you can't really know where a bulge is going to go. I mean, I can't, but maybe the best radiologists will know, but you don't really get to talk to those people. So that's really how I would go about it. And I would imagine the bulge kind of has a consistent way of direction of bulging. I would guess that. And it's not towards the sciatic nerve, it will be towards the root nerve. So there are 5 root nerves, I believe 5, that come out of the spine, and later, after they've exited your pelvis, they come together and form the sciatic nerve. So it would only be most likely one root nerve, like if it's L5S1, it would probably be the L5 root nerve that it's pushing on. Could be S1, who knows? And then, trial and error, listening to your body is the answer to that. So when I perform the back anchor and push away, is there a natural flattening of the lumbar curve? Yeah, a natural. The way I would look at it. Let's read the rest of your question. Does this exacerbate the problem of a bulging disc by unnaturally moving the curve away from its natural state? So the way I would look at this, Matthew, is, okay, go full screen. So many people have, and with back pain, have a more anteriorly tilted pelvis. It's proven in the research. It's not a question. It's a pattern, okay? And so when your pelvis is tilted anteriorly, the arch in your lower back is actually increased. It's a little bit more accentuated than the natural curve should be. And so when we are connecting the back anchor, there is a subtle flattening of the curve, but the goal is not to flatten the curve. The goal is to connect your back anchor. And that's a very natural thing to do. It's modeled after what infants do when they're developing their core. And as a result of connecting your back anchor, the curve will decrease a little bit. And that is not, it's not eliminating the curve completely. It just takes it from that excessive or exaggerated curve to a little bit less curved. And that typically feels good for people. And so that is the way I would look at it. And I would not really focus on what my lower back curve is doing. I would just connect to the back anchor, which is not your lower back, right? It's the rib cage in the back. I would connect that and let the lower back, let the lumbar spine go for the ride. Whatever it's going to do as a result of your intention, which is to connect the back anchor, let it do that, and let it do that naturally and feel how that feels. And if it feels good, then do more of it. And if it doesn't feel good, then you're going to need to change something. And that's when, we would cross that bridge if it got to that. So hopefully that helps explain things for you there. And I know that question is probably kind of common. So yeah, we're not intentionally flattening the back. So let's go to the next question here from Andrea. And she says, as I'm stepping through these exercises and working with a PT to get my left innominate to not rotate posterior, a good day means to me that I don't feel stuck on the left side and feel like I need to shift around till it clicks, which I try not to do since it's not really a normal physiologic motion that I have to do to get it to click. Okay, so you're talking about your left innominate, and this is also the left side here. Okay, and then the other thing is that I don't feel pain and inflammation just sitting. Okay, when I have these decent days, instead of stability, I feel a pulling or tugging on the posterior iliac crest if I bend forward. Feels like I need to stretch it out, but not try to. But I try not to. Can you enlighten me on what this may be? Okay. It's the same pull and tug I feel on the left posterior when I try to bring my pelvis up from the floor with the front anchor progression. Front anchored progression. We're not bringing our pelvis up from the floor on the front anchored progression. So that would be the first thing I'm focusing on. With the front anchored progression, we are bringing the pubic bone to the floor, into the floor, and pressing it into the floor. And that's the fulcrum. And as a result of that, the legs will float up. So if you meant back anchor progression, then you would be pushing away from your back anchor, and the pelvis would elevate as a result of that. So we'll just to make that clear. Okay. So when you have these decent days, instead of stability, I feel pulling or tugging on the posterior iliac crest. If I bend forward, feels like I need to stretch it out. Can you enlighten me on what this may be? Well, I'm not going to say that I know exactly, but my feeling is that since you have a left to right imbalance, so one side is rotated forward on the other, then the muscles that are attached are going to be out of balance left to right. And so there may be a muscle that's either trying to pull you back into place or just trying to protect because it feels like the body is at risk of being injured, or maybe there is some damage taking place. And so muscles typically tighten for protection or of either themselves or the joints that they move. And that is often why muscles will tighten. And the other reason would be if the muscle is not strong enough to function in the range that it's being asked to function, then the muscle will tighten to protect itself and not so that it doesn't get exposed to the vulnerability of that range where it's not very functional. So that's my thought is probably a muscle, and that is protecting. The one thing that I would recommend for you, Andrea, is that if you're getting your left innominate or the left side of your pelvis, for people that are wondering, adjusted regularly and it's not staying, then the problem is actually an instability. And so what you want to do before getting it adjusted is you want to create stability. Even if it's out of place, you want to try and set it by squeezing your glutes or doing some muscle energy and try and set it yourself, and address the left-right imbalance as much as possible. So anytime you do an exercise that's left-right, unilateral or asymmetrical, like bird dog or dying bug, I would be spending more time on the side that is weaker or has less endurance to try and even out the two sides. And that would be an ongoing process over months. And then I would be trying to create stability in the SI joints through the bridge and the butt buster bridge, the SI joint stabilizer bridge. And then I would try and get it adjusted by your PT as few times as possible, because every time you get it adjusted, it's contributing to the instability, if that makes sense. So I'm trying to space out the time between adjustments until the point where you completely wean off the adjustments. And the only way to do that is before the adjustment and immediately following the adjustment, you work on stabilization so that, it gets adjusted, then you keep it there. So hopefully that helps for you. And then we have John Lannon. And John says, I feel like I need to do more lumbar extension work, cobra extension push-ups to balance out the bridging and back ankle progression exercises. Okay. Just going off of intuition here. Also don't understand why extension of the left leg would cause pain in the right leg. I feel like this is a clue for the overall situation not getting better. So I definitely am in support of intuition, John. So that's actually something I'm going to say, yeah, listen to that and do that. The other thing I'm going to say is the bridge does involve extension, right? So there is going to be a little bit of natural spinal extension in the bridge. It is working the lower back muscles. So that is going to be, that will support the intuition that you want to do. There are people who fall into the 20% category who will benefit from lumbar extension and spinal extension. So that you might be one of those people. And also, if it's something you've been doing for a long time, leading up to this time, then it could be that you are accustomed to it. You're familiar with it, and your body maybe even be a little dependent on it. So those could all be reasons where you have a desire to do that stuff. But I would listen to my intuition if I were you, and I would let that guide you throughout the program. So the other point you ask is you don't understand why extension of the left leg would cause pain in the right leg. So extension of the left leg is going to pull it lengthens the hip flexor. It puts the hip flexor on fully taut. And when that happens, it's going to pull the left leg, the left side of the pelvis, into an anterior rotation. And so when that happens, everything's connected. And so the right side could be also getting rotated in a way that it's pushing on a nerve or just making a tissue that is compromised, like a strained tissue, taut. And so it is a clue. It's 100% a clue. I would definitely look at it. I like the way that you're looking at all of this stuff, and I would let those clues guide you. So it seems to me like there is a left-right imbalance in your body, and I would make it a goal to even out the length in my left and right hip flexors, and continue to listen to your body just the same way that you are. So hopefully that helps for you, John. And then the last one is from Jessie. She says, I have faith that I can restore my body to balance with this program, but there either has to be something I am missing or maybe need to take time off from work and do as little as possible for a while. So it's with her SI joint. She's said she's been doing everything and her SI joint is continuing to get worse. So there are some situations, Jesse, where it is beneficial to take work off. It's beneficial to, completely modify your life, where you do the thing, whatever it is that's hurting you. So if it's your job, then to do absolutely none of the thing that's hurting you for a short period of time. For me, in my past, it's been sitting. And I have had periods of my life where I've said, okay, I'm just not going to sit for 3 days. And those periods of time actually were massive periods of progress for me, because I stopped doing the thing that was hurting me. And it was very clear to me that sitting was hurting me, because my body communicated that to me for years. And so not only was I not sitting, but what do you replace sitting with? Well, you have to replace it with either rest in bed or movement and activity and exercise. So not only did I stop doing the thing that was hurting, but I was doing a lot more of the things that were helping during that period of time. And so, yeah, if you can swing it, I would recommend doing like a staycation from work, get a little bit of a paid vacation if you have paid time off, and just taking that time to do like perfect days for your body. Do the opposite of the things that you do at work. Do core balance training, and sometimes eliminating the thing that's hurting you is equally or more effective than doing the right thing that's helping you. So I do strongly recommend that you listen to your intuition there about that, Jesse, as well. So hopefully that helps for you. And we'll take one more look into the chat, and then I'm going to sign off, and we'll do it again next week. So let me see. We have Charles. Nope, that was... I guess we just have Marina. For Matthew A., great visual on the nerve roots forming into the sciatic nerve once exiting the pelvis is shown in our recent Instagram posts. Oh, all right. Thank you, Marina. So I guess there's no more questions in the chat. I'm going to sign off. I have a harder time talking because I have an expander in my upper palate, and so I'm very tired from talking right now. So we're going to sign off. I want to thank everybody for being here live, and if you're catching the replay, thank you. Feel free to support the channel by hitting that like button. Share the stream with any friends that you have or family that you love and you think this might help. And until next week, get down on the floor and connect to your core. All right, take care, everyone.